So without further ado, Dr. Sheldon Fields.
Thank you, Dr. Chandler. Welcome, ANAC family. And I say ANAC family because I truly do feel that way about ANAC. It is my absolute pleasure to be here to talk with you about the work that I've been doing lately and even post-pandemic. As an educator, these are the three things that we're going to talk about. You can read them yourselves because you can read. Some disclosures. So I'm going to speak about my lived experience. I've been a nurse this year for 32 years. I know I look younger. You don't have to tell me that. But what I'm going to share with you all really is a little bit about my lived experience as a Black Latino man who just so happens to also be a registered professional nurse. I start all of my presentations with this quote: "Of all the forms of inequity, injustice in healthcare is the most shocking and inhumane," by Reverend Dr. Martin Luther King. This grounds the work that I do in social health justice, and it reminds me about why I do the work that I do. Okay, I'm going to start with this. This is the ANA's Reckoning apology by Dr. Larissa Cole, and most people have not seen it. So we're going to take a listen to what Dr. Cole had to say, then I'm going to come back and we're going to talk a little bit about why this was so important.
Hello, I'm Dr. Larissa Cole, Chief Executive Officer of the ANA Enterprise. On June 11th, ANA's highest governing body took historic action by unanimously adopting a racial reckoning statement. This statement is an overdue public acknowledgement of ANA's history and past behaviors that contributed to marginalizing nurses based on their race and ethnicity. A critical step in this journey is for ANA to own and apologize for its inactions, and complicity that have seriously hurt nurses of color. Throughout its 126-year history, ANA has strived to lead the nursing profession. However, we have not lived up to that ideal. Our actions have not aligned with our values, and ANA owns that. We caused harm and perpetuated systemic and structural racism. ANA's racial reckoning statement serves as a starting point for the hard work that is necessary for our organization. We understand that it will not right all of our wrongs. On behalf of ANA, I ask every nurse of color to accept our deepest apology for the harms caused by ANA's past actions. To all the past and present leaders of ethnic minority nursing organizations, we apologize. You led where we fell short and failed. We commend you for your unapologetic commitment to serving the needs of nurses of color. We also understand that our apology may not be accepted nor appreciated by all. I am asking that you read ANA's racial reckoning statement in its entirety, really sit with it, and fully embrace the emotions it may evoke. Today, and as we move forward on the journey of racial reconciliation, we are committed to standing with integrity on the right side of history. Through genuine acknowledgement, accountability, and reconciliation, we strive to restore trust, healing, and unity.
How many people had ever heard it? Raise your hand. See? Very little. So here's why I personally think this is so important. For the first time in my 30-something years of being a nurse, you have a major nursing organization taking accountability for what it actually did and apologizing. No other major nursing organization has done this. Now, as Dr. Cole said, it's really just the beginning, but we need to start somewhere with this. Now, I was introduced in my introduction as being the national first vice president for the National Black Nursing Association. And a lot of times people will come up to me and say, Dr. Fields, why does there need to be a National Black Nurses Association? We don't have a National White Nurses Association. And I back them up. I go, that's because you don't know your history. And if you know the history of the American Nursing Association, you know that as a matter of policy, the American Nursing Association excluded membership for any nurse of color. When you take out nurses of color, what are you left with? White people. So you had your white National Nursing Association. So the other question I get is, but Dr. Fields, what are they apologizing for? Again, you have to know the history. When the nurses of color could not join ANA, they formed an organization called the National Association of Colored Graduate Nurses. The National Association of Colored Graduate Nurses, for years, asked ANA for membership and equity within ANA. The American Nursing Association in 1951 finally said to them, okay, well, we will give you membership. As a condition of membership, we want you to dissolve the National Association of Colored Graduate Nurses and just become a part of ANA. They did it, and what do you think happened? True equity, true representation in ANA never really materialized. It was 20 years later, in 1971, that the National Black Nurses Association come into fruition into what we know it today because of what the ANA had failed to do. And people like Mabel Keaton Staples, who a lot of people in this audience have never heard of, really worked for years on that organization. Now, when you understand the history, you start to understand that racism has always been a part of the nursing profession, but nursing has not always owned it, nursing has not always acknowledged it, and nursing has been complicit in institutional and structural racism, just like Dr. Cole said. And the other thing is, too, is when you think about healthcare in general, and I want to put this out here to think about, I think about healthcare as a basic human right, not a privilege. In the richest country in the world, that is really what healthcare should be. That's not the system that we have. And as you can see, I'm not the only one who thinks that. You know, late Senator Kennedy thought that way also. So we're going to talk a lot about some definitions, and there's a lot of information out there about, well, if you're talking about how are you defining all of these terms that are now out there, because, you know, racism and diversity are all used as buzzwords. All your institutions have some type of diversity initiative post the death of George Floyd, but my question always is, does it really have substance? So when I talk about justice, I talk about that quality of being just and about treating people fairly. When I talk about equity, equity is the ability to recognize differences in resources and that people don't need the same resources because they don't have the same need. When I talk about diversity, it's everything that makes us unique. Now, a lot of times people think about diversity in two big buckets. They think diversity, race, ethnicity, and gender. Well, there's a lot of other ways to be diverse. And when I talk about it as a diversity officer and a diversity practitioner, I talk about the totality of diversity. When I talk about inclusion, we talk about those things that make people feel that within an organization or structure, they truly feel seen, heard, and respected. And therein lies the caveat about being respected in an organization. But I'm going to do it a different way, because I know I'm not the only one out there with a shoe fetish. So I'm going to give you a lesson based on shoes. When it comes to equality, everybody gets a pair of shoes. You get a pair, you get a pair, you get a pair. Very Oprah Winfrey. We share the same birthday. That's my big sister in my mind. When I talk about diversity is everybody gets a different type of shoe. You think about equity, not only do you get a shoe, but you get a shoe that actually fits. When you talk about acceptance, now we understand that we all wear and can wear different types of shoes. Now you talk about belonging. Belonging is wearing shoes that you really want to wear without fear of somebody judging you. So, there you have it. So, One of the other things that we don't do very well in nursing, and I'm a Robert Johnson Health Policy Fellow, we don't talk about politics. It's sort of like, you grew up talking about, you don't talk about sex, money, and politics, right? Well, we're ANAC nurses. We talk about all that. But we don't really talk about politics. Daniel Dawes, who is brilliant, he talks about the political determinants of health. And we live in a very politically divided nation. We all just went through an interesting election, and we're standing in the state of Florida, and never mind. I'm not going to go there. But we live in policy is in everything, especially in healthcare. And one of the main things we did as a Robert Johnson Health Policy Fellow is I actually worked on and helped to pass the Affordable Care Act. And when you talk about the core political determinants of health, it's voting, and all everything that people have been done to suppress voting. It's knowing what type of governmental structure that we actually live in. I'm always interested when people go, oh, we live in a democracy. I don't know what democracy you live in. I live in a democratic republic. Because I think we did a very bad job of civics in this country. We don't even know what type of political government you have. But that is because we vote for people who then vote for us. It's a representative republic. And then all of the policies that are created and enforced. Take, for instance, the annual allocation for the Title VIII funding for nursing and nursing education. What a lot of people don't appreciate is, yes, it's on the books, but it has to be annually appropriated in the federal budget, and as nurses, we should be able to flex our political will and our muscle to make sure that we advocate for passing that. All right, one of the other interesting things about our healthcare system is we all know that our healthcare system is historically has been not accessible and not has treated everybody fairly. Now, you've heard of some of these historical medical atrocities that have led to medical mistrust for certain populations. Everyone particularly knows about the Tuskegee syphilis study, or as my colleague says, the United States Public Health Service syphilis study, because this was our own government who did this study. A lot of people don't understand that. You've heard about Henrietta Lacks, whose cancer cells became the whole generation for the HeLa cell line. Well, the problem was they took the cells without her consent, and her family were never fairly compensated. Very few people have heard about the Mississippi appendectomy, which took place mainly in the southern United States, where white physicians were trained in obstetrics on mainly women of color. They did all types of sterilization on poor women for practice without their consent. Fast forward to the dying declaration of Dr. Susan Moore. And you gotta take a look at the video because I really can't do it justice. But she was a black physician who claimed that she was being discriminated against in her treatment against COVID. And she actually did die of COVID. And this is just how broken our system is. Not even a black physician could get the treatment that she felt she needed. We have known that there's unequal treatment in our healthcare system for decades. This is the landmark study from the Institute of Medicine way back in 2003 that simply said that when all things are equal, the ability to pay, the access to insurance, that you have insurance, even when everything is equal, minorities still received a lower quality of care than their white counterparts. And one of the main reasons that I highlighted here is that healthcare providers have bias, prejudices, and their uncertainty when treating minorities, all of the isms, stereotypes, and the lack of communication. So we have known this for a very long time. What we haven't done is put forth efforts to really move this needle and to change anything. Because health disparities is an outcome of what is the unequal treatment in our healthcare system. Because people who have healthcare disparities, based on a lot of times you'll see it worse for people along racial or ethnic groups, their socioeconomic status, or their sexual orientation. So here's a question that also then comes up at this point. So what does this have to do with racism? What does racism have to do with the nursing profession? If we truly believe that racism is a public health crisis, And we saw this post the death of George Floyd in the midst of the COVID pandemic. We also had a whole other pandemic going on in America. That was the pandemic of racism. And we already know that nursing is the largest segment of the healthcare workforce, 4 million plus strong. And we are the most trusted profession. We all know that. We're all nurses. We lost it 1 year to the firefighters. We got it right back. But here's the thing. We do not talk about nursing in a way that encourages the most diverse populations to ever become a nurse. So think about this. I talk to kids, I go out and I talk about nursing. And you go into a 4th grade class and you go, what do you want to be? I want to be a firefighter, I want to be a policeman. No 4th grader goes, I want to be a nurse. It doesn't happen. Something's wrong with the pipeline and we don't talk about it. But nursing is also at 90% female and 80% white. Nursing is not gender nor racial or ethnically diverse. I'll say that again. The profession for the longest time has not been gender or racial or ethnically diverse. And that's across any category that you look at in terms of the percentage of ethnic minorities in the population versus the percentages we represent in the profession. And if you look at the fastest growing, which is the Hispanic and Latino, at almost 19% of the national population at only 5.3%. And these are 10-year spans. So in 10 years, that needle hasn't moved. Now, you might look at that graph and go, oh, look, we're doing okay with the Asians. Look at the Asians, that's good. So here's the problem. No Asian, they grouped all of the groups that could be considered Asian, they put them in one group. Asia's not a monolith. When you break it down, the devil's always in the details. When you break down the intra-ethnic differences, they also do not mirror their populations as well. So here's the other little problem that we have, and here's why we need to pay attention. We leave out qualified nursing students out of nursing school every year, 80,000, and this is qualified, who are eligible to go to nursing school, but we can't get them into nursing school. 60,000 at the undergraduate level, and you can see how the numbers work out into RN to BSN, master's, and doctoral level as well. So why is this important? Because I look at this number and I go, how many of that 80,000 are racial ethnic minorities and people who identify along the male continuum that we are leaving out of nursing because we can't figure out how to solve our shortage of clinical site issues, faculty, and other resource constraints. Now, I know there's faculty in here. How many people are faculty? All right. So here's a difficult conversation I had with my mother when I finished my PhD, because she really couldn't understand my madness. She was like, let me understand, baby. You just got this PhD, and you're going to go take this faculty job, and you're going to make less money than when you had a master's degree. I said, yes, Ma, yes, I am. And I'm only going to be paid once a month, and I got to move to a part of the country that's mainly white. She didn't understand. Hell, I didn't understand. But here's the problem. Now let's talk about some trends, because nursing is wrapped up in these trends. So, the baby boomers, those of you who are baby boomers, now I'm a Gen X, I know, I told y'all I look younger. I am not a baby boomer, I am Gen X. But I know some of you are. But the baby boomers are gonna retire. Hell, I'm gonna give y'all 10 more good years and I'm out. But the population's aging, so if you're in a hospital, the acuity level is really high. Nurses have lots of other options. They're not staying at the bedside. And nurses were also a part of the Great Resignation. Many people just was like, oh, no, I'm out. I can't do this anymore. So we're going to have another cyclic nursing shortage. Now, we've had nursing shortages forever, but we're going to have another one. Because the average age of a nurse is 52. I remember when that number used to not include me. But we're aging. But the black and white nurses are actually aging a little quicker than the Asian and the Latino nurses. Here's one thing that's very disturbing. 80% of nurses say that their units are inadequately staffed. I just got an email from a student at Penn State, and she's a student who's she has a chronic disability, and she needs home care services or services to help her go to class. She cannot get coverage for half of her classes because the staffing agency doesn't have a nurse. So now my nursing students are filling in. We're filling in. But think about that for one moment. There's shortages all over. Men in nursing. When I became a nurse, again, 32 years ago, we were about 5%. Now we're about roughly 10, 12% of the profession. But it took 3 decades to almost double the number. Why? Why? When other countries seem to do it a little better. Now, let's be honest. How many of you have read the 2020-2030 report on nursing? See, not even half of you. This is the roadmap. This is the roadmap for the future of the profession, done by all of those people in the illustrious Illuminati of the American Academy of Nursing. But this really is important because it centers how nursing is going to be used to help the country to achieve a level of health equity. And it states that one of the ways we're going to do it is this elimination of the disproportionate disease burden carried by specific segments of the U.S. population. That's healthcare disparities, and they're talking about historically underserved people. And one of the things they also say is that nurses should reflect the people and communities served throughout the nation, helping to ensure that individuals receive culturally competent, I say culturally relevant, equitable healthcare services, and that healthcare systems should really enable and support nurses to really tailor their care to meet the specific medical and social needs of diverse patients to optimize their health. It also calls up the leadership that nurse leaders have a responsibility to address structural racism, cultural racism, and discrimination based on identity, all of those things that makes us who we are, both within the profession and outside of the profession. So this is the roadmap, and most of you haven't read it. So take a read, because this is what we're all supposed to be doing. So now, if we're going to achieve health equity, I'm going to offer a different definition of health equity than the 2020-2030 report. This is the definition of health equity by Dr. Kamara Jones. Dr. Jones was the former president of the American Public Health Association. Just put her name into YouTube and watch her videos. The woman is absolutely brilliant and amazing. Dr. Jones defines health equity as the assurance of the condition for optimal health for all people. Very short, to the point, and eloquent. She also says that we can actually achieve health equity if we do 3 things. If we provide resources according to need, if we value all individuals and populations equally, and if we recognize and rectify historic injustices. Remember the historic injustices I talked about, Tuskegee and whatnot? So Dr. Jones is very clear. Don't ignore it. Talk about it, rectify it, and heal from it in order to move on from it. Now, health equity also comes in different times and waves, and when I look at the current situations, I always look at it from a health policy lens, and that issue of health equity is always in the back of my mind. So when I think about the health of marginalized communities, think about homeless populations, LGBTQ populations, those suffering with mental illness, that's bad enough. Then I think, what if that same person who is homeless is also BIPOC, Black, Indigenous, person of color? So now, what do you have going on here? You have a compounding effect. That is intersectionality. And you talk about transgender healthcare access. You've all seen it. You've all seen the legislation. Some of you work in this area. So imagine again, we're talking about access to gender-affirming care services, all of the issues related to the transgender athletes. Now imagine if that same athlete also happened to be BIPOC. Now, when it comes to smoking and the targeting of these companies do there is evidence that the tobacco companies specifically target poor and people of color communities disproportionately. And reproductive health justice. The SCOTUS decision is going to have more and worse implications for women of color, period. Period. Because if you don't have money to leave one of those red block states to go get what you need, you're going to have very few options. Okay, so we cannot achieve health equity in nursing without an intentional agenda to also achieve diversity, equity, and inclusion. Now, how are we going to do that? We're going to do it by two ways. Nursing needs to become comfortable with embracing actually doing health equity work and doing anti-racist work. If you don't believe that you have a responsibility, look to provision 8 of the nursing code that we all took. It simply states that the nurse must collaborate with other health professionals and the public to protect human rights, promote health diplomacy, and reduce health disparities. It is part of what we are supposed to be doing. And I say to you, we cannot reduce health disparities if we're not doing anti-racist work and if we're not embracing health equity. I really love the definition of the World Health Organization about healthcare disparities. Differences in outcomes that are closely linked to socioeconomic environmental disadvantage, often driven by social conditions in which individuals live, learn, work, play, and die. They don't add die, I add die. Now, I don't know if you've ever heard this statement, when white folks catch a cold, black folks get pneumonia. And that is very simple, that because of the inequities in our healthcare system, even a simple rhinovirus, which for a lot of white people just, amounts to a cold, but can be compounded in people of color and have a worse healthcare outcome. And even when you look across all these chronic health conditions, high blood pressure, diabetes, stroke, African Americans as an exemplar, all across each age strata, from younger to old, actually have higher levels and incidences of all of these causes. This is the most egregious, or one of the most egregious healthcare disparities in our country. It is the black maternal death rate, which is 3 times higher for black women than it is for white women. This is normal pregnancy. This is nothing complicated. Now, you know there's a problem when both Queen Bee herself, Beyonce, and Serena Williams both had problems giving birth. And heck, they got more money than God. Something's wrong with our system, and we have to address this. Nursing is part of this. And there's a lot of discussion about the lack of diversity in access to things like doulas, which are more acceptable to women of color, and the lack of OB specialty amongst black nurses. Here's breast cancer. White women have higher incidences of breast cancer. Black women have higher death rates because of the system of getting access and getting timely treatment. Now, how many of you, when COVID came up, and I'm talking to a room full of HIV nurses, how many of you had this deja vu moment? Didn't you have a deja vu moment? I was like, oh shit, why do I feel like I'm back in the early 90s when I just got out of nursing school? It felt like we were right back in the early days of HIV/AIDS, yes? So, and I know I wasn't the only one, because, I talked, a lot of times to a lot of you during that time. But we had very similar outcomes too. We quickly realized, even in HIV/AIDS, that this was disproportionately affecting certain communities, and it disproportionately affected communities of color who had worse outcomes. And a lot of times people say, well, Dr. Fields, what was the problem? So there was an overrepresentation of blacks in the quote-unquote essential workforce. There were some people who literally had to go to work. They had jobs that they had to go to work. Now, a lot of us as nurses also had to go to work. But could you imagine being a black nurse during COVID, working, saving people, getting, everyone's clapping for you, pots and pans, we're celebrating you, but yet on your way home, you got stopped by a white cop Because you were driving too nice of a car. And that's reality. That's racism. Historical trauma played out in population density. You know, in certain areas because of the population density. I mean, I grew up in New York City. There is no social distancing on a New York City public train. That doesn't happen. You know, you might meet a date on the train, but that ain't gonna happen. All right, I appreciate this slide about healthcare disparities from the Kaiser Family Foundation because it overlays the issue of racism and discrimination. I'm going to give you one example that was very personal. So, in Buffalo, New York, that community that was ravaged by a shooting in the Tops grocery store. So I used to be the board chair of an organization called the Men of Color Health Awareness Project. And we had an office in Buffalo, New York, and in Rochester. And our Buffalo office used to do outreach in that very same neighborhood. I had personally been in that grocery store. So an act of racism, race-related gun violence, led to that community now dealing with issues of food insecurity because the grocery store had to close after the grocery store is still closed, and it was the only grocery store in that neighborhood. There you have the social determinants of health interacting with racism and discrimination in a way that I hope is now very clear to everyone in this audience. Again, so what does this have to do with the nursing profession, Dr. Fields? So, what can we do as nurses, as nurse practitioners? We are 4 million plus strong. On the NP side, we are growing. We are now have passed the mark where we have more than half the states. We now have full practice authority. We are the most trusted profession. We have a responsibility. We can do a lot. But achieving health equity will only be possible if we confront structural and institutional racism, and again, if we embrace doing anti-racism nursing initiatives. So the first thing is the difference between a racist and an anti-racist. I take my definition from Dr. Ibram Kendi, the author of How to Be an Anti-Racist. Has anyone ever read his book? Please do. It's excellent. I highly recommend. Dr. Kendi says that there's no difference, there's no in-between, that you're going to have to choose. You are either a racist or an anti-racist. And no, you don't get away with, but I'm a good person. I have black friends, and I voted for Obama twice. That's not it. And he simply says, a racist is simply somebody who endorses the idea that there is actually a racial hierarchy. And an anti-racist is someone who endorses the idea of racial equality. It really is, in his mind, that simple, and I actually agree with him. It is racism, not race, in America that is the issue and that is a driver of healthcare disparities. It is racism. Because on a genetic level, we are all 99.99% the same. Racism, biases, and prejudices are taught. You are not born a racist. They are taught. And what can be taught can also be untaught. But we all saw the rise of the Black Lives Matter movement in the post-George Floyd era with all of those people who died at the hands of white law enforcement officers. But America has amnesia about its history. America in its current form has not existed for as long as it was a slave country than it has a non-slave country. So you cannot reverse those 400 years just that quick. It doesn't happen. So let's find some common meaning. Racism, again, a belief that a race is a fundamental determinant of human traits and capacities, and that racial differences actually produce an inherent superiority. An anti-racist is someone who refers to a form that against hatred, and it really talks about one's actions and being intentional. And again, I already told you what an anti-racist is. But I'm going to give you a definition again by Dr. Kamara Jones of racism. Dr. Jones defines racism as a system of structuring opportunity and assigning value based on social interpretation of how one looks, that's what we call race, that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. I think she hit it right on the nose. That is the unmitigated impact of racism. There are two forms that we talk about racism. We talk about structural, I mentioned it before. Now that's a system in which the public policies, everything in this institutional practices more favors everything that centers whiteness and disadvantages anything seen related to people of color. When we talk about institutional, talk about those things and practices that go across, that intentional or not, produce outcomes that chronically favor or put one racial group at a disadvantage. One of the really good examples of all of this around employment is the classic study whereby you have two resumes that are exactly identical with only one difference. One resume has a Eurocentric white-sounding name. One other resume has more of a person of color or ethnic-sounding name. Who do you think gets more interviews with the same resume? Time and time again, the resume with the white Eurocentric name even gets called for more interviews. That is institutional racism, whether it is acting out intentionally or not. So, being honest again, my colleagues, how many of you have read the National Commission to Address Racism on Nursing? Raise your hand. Okay, so aren't you glad I came today? So, the National Commission, and this is your homework because you're going to get this link, you got to read this report. It's a companion report that goes with the 2020-2030 report on the future of nursing. And its mission is to set as the scope and standard of practice that nurses confront and mitigate systemic racism within the nursing profession and address the impact that racism has on nurses and nursing. And the report is out, it's online, it's free, please download it. So why is this important? One of the things that the commission puts forth is a new definition of racism for nursing. And here's how they define it for nursing. They define racism as assaults on the human spirit in a form of biases, prejudices, and an ideology of superiority that persistently cause moral suffering and perpetuates injustices and equities. It talks to the human impact of racism. And I actually think it's a pretty helpful definition for what we need to do in nursing. What did the commission also found? The commission found that 56% of all nurses say racism in the workplace has negatively impacted them. 63% of nurses have personally experienced racism in the workplace. 3 out of 4 nurses have witnessed that racism in the workplace, and 92% of black nurses, 73% of Asian nurses, 69% of Hispanic nurses have all experienced racism in the workplace. So, what else did the commission put forth? The commission also said, okay, now that we know that racism is this pervasive within a profession, how can you intentionally be anti-racist in nursing? So now, here's the fun part. So, they put forth the 10 ways to be intentionally anti-racist. How many of you have seen it? All right, so we're gonna go through them. All right, the first way is to become a story catcher. So now, I know I'm talking to my fellow ANAC family. So this is about listening to your patients and each other. Because once you do that, you can become a more empathetic person. It's really hard to be both racist and empathetic towards the same person. Imagine that. Be genuine. From the early days of the HIV/AIDS pandemic, it was nurses who were seen as allies. Yes? Yes. We're good at being allies. We're good at being genuine. Because you couldn't go to those patients in the early days because they saw right through your bullshit, right? They did. See, I'm not the only one. Manage me. The amygdala. So you need to reject the stereotypes about people that society has taught you. I am very aware, as a black man in America, that society has taught America some very interesting things about who and what black men are supposed to be. To the point where I can still get on an elevator with a single white woman and she's standing in the corner clutching her purse. Now, hell, I have a fucking PhD in nursing from an Ivy League school, and I'm thinking to myself, girl, I got more money in my wallet than you do. I should be clutching my purse. And now, I know some of you have had some scary conversations with me over the year, but I don't think anyone's afraid of me. So you got to reject those stereotypes. Maximize your curiosity and minimize your certainty. Give people the benefit of a doubt is really what they're talking about. Distribute power. Check yourself and your organization. If you are working in a place and you're sitting around tables with only people who look like you, change it if you have the power to do so. Distribute your power. Preserve the dignity of others. What is that talking about? View everyone as an asset and see the assets they have not as a deficit. Stop labeling others. Reject the human hierarchy. We like our hierarchies, and we like to put people in their place. It doesn't always help. Expose unwritten rules. If you expose unwritten rules, you expose bias that makes change difficult. And it's actually more based on what is actually going on in the real world. How is things really, really working? And you need to work with those populations to make sure it's working for them. We need to support authenticity, celebrate uniqueness, celebrate somebody wanting to use their pronouns the way they want to, celebrate somebody coming and dressing the way they want to, celebrate people showing up with the type of hairstyles they want to show up with. I remember that when I had hair. We talk a lot about gender nonconforming. We need to support that authenticity. Let your freak flag fly, and it shouldn't matter. Manage perceptions. Think about the unintended consequences of your decisions, which could be different than your intent. And in health policy, we call that unintended consequences. So there you have it. Be anti-racist. Now, here's the other thing we need to do in nursing. We need to intentionally decolonize nursing history. So, I'm probably going to offend some of you who also believe that Florence Nightingale is the mother of modern day nursing. Flo did some work, and I'm not saying she didn't do what she did, but Flo was also a racist. She was a white privileged woman of her time. And we know about what she did in the Crimea War. We don't know about people like Mary Seacole, who was an Afro-Caribbean nurse who also did work in the Crimea, went to Florence and was like, hey, how about I go with you? Florence was like, no. She went herself. If you've ever been to the museum about Florence Nightingale in London, I've been. So they finally put a bust in there talking about the contributions of Mary Seacole as well. We need to tell the totality of nursing history, and we need to update our history. So I'm going to tell you a little bit about one person you should already know about, who's Mary E. Mahoney, who was the first professionally trained black nurse in America. She went to a school at a time that had a provision for the admission of one Negro and one Jew. Guess which one she was? But by policy, the same way people don't appreciate that at one point in this country, people of color could not go to nursing school, and men couldn't go to nursing school. Hell, men couldn't even serve in the Army Nurse Corps until 1965. How messed up was that? Talk about racism, bias, and discrimination within the system. But I'm going to tell you about 3 men that I think should be written into modern day nursing history, and that are my mentors. So, if you don't know, I want to introduce you to Dr. Randolph Rash, who was the first African-American man to get a PhD in nursing science. And when I met him, I cried because, God damn it, I'm not the only one. And at the time, he was a trailblazer. He made me feel less alone. Because people would look at me like I had three heads. Every place I applied, oh, you're going to be the first one, you're going to be the first one. University of Rochester, you're the first black man we ever hired. Well, damn it. Okay. Nothing I can do about that. Now, most people now know who Dr. Ernest Grant is, but even my nursing students, I always ask them, look, who is the president of the American Nursing Association? All of you want to be nurses. Y'all should know this. And they go, I don't know. Go pull out your little, dumb phones and Google. So they Google, and you can see their faces. It's like, oh, it's Dr. Ernest Grant. Okay, what do you notice about Dr. Grant? He's what? Come on, you can say it. He's black. And he's also a man. He's the first man to ever be president of the American Nursing Association, white, black, or indifferent, in its 136-plus year history. What the hell took so long? But the man is absolutely brilliant, and if you ever met him, you would remember because you're probably looking up because he's almost 7 feet tall. And he's such like a big teddy bear. I want to introduce you to Dr. Courtney Leiter, who was the first black man to ever be named a dean of a major school of nursing when he became dean of UCLA. Dr. Leiter made me believe that I could also one day become a nursing dean, and I did. We set up a website called Nurses You Should Know to talk about the contributions of nurses of color. We launched it almost 2 years ago. It's on there, it's out in the web, it's a resource. Please use it because it tells the totality, it tells a more inclusive nursing history. So how can you increase your intentional nursing actions? As members of the most trusted profession, we are all key opinion leaders. Use your power as nursing leaders. Advocate for and demand more rapid change in our profession. Demand more DEI programming and the hiring of DEI nursing professionals such as myself. A lot of schools and colleges of nursing, I know I'm speaking now to my nursing dean friends. Now everybody wants a DEI associate or assistant dean. You can't have me, I already have a job, I like my job. And they pay me very well. But they need more because this has now become a specialty in our profession. We need to advance the teaching of a more inclusive, decolonized nursing history. Tell the whole truth. As alumni, direct your dollars to support DEI initiative programs and scholarships. As nurse practitioners, continue to precept that next generation with intentional inclusion of those who have been historically underrepresented. Support changes to nursing school admission policies and progression policies. Standardized testing, SATs, GREs, they're all been proved to be racial bias. So what did nursing do? Nursing ran out and said, oh, we're going to do a TEAS test. What the hell is a TEAS test? And why do we need it? Why did we put up that barrier in nursing? I'm serious. Why do we do that? And what is this thing about progression through nursing school? If you get a C, you are somehow unworthy to be a nurse. You know how many doctors got Cs and they're still doctors? Why do we do this to our nursing students? Because I'm telling you, from my experience, 30 plus years in the academy, you know who gets C's? It is that young single mother who's trying to improve her life. And she's more than likely a person of color. It is that first-gen student who doesn't have the financial resources not to also be working. And I was one of those students. Now, I ain't get a C, but that's not the point. My point is, the policies don't make any sense. All right, demand for nursing is growing. We have some trends out there to say that we're in trouble. The lack of diversity, equity, and inclusion in nursing is driving healthcare disparities. Nursing has a moral and ethical obligation to address DEI issues and diversify the profession. The structural determinants of health and the nursing determinants of health and racism are all present in nursing, and they are also driving healthcare disparities. The 2020-2030 report on the future of nursing is the roadmap and where nursing needs to go and centers this whole issue of achieving health equity. The ANA National Commission to Address Racism provides intentional and practical ways to deal with racism in our profession. All nurses can increase their cultural awareness and their advocacy. The benefits of diversifying the nursing workforce for patients in society and the profession itself are profound. Lots of resources. Love this video on institutional racism. It explains it to the tunes of Michael Jackson. It's tune We Don't Care About Us. I'm an 80s kid, love Michael. More references. I always hide in public. And the last thing I will say, as the first vice president for the National Black Nurses Association, I put my money where my mouth is. I'm also the chair of NBNA's Health Policy Committee. You are all welcome to join us on the first Thursday in February, where we do our National Black Nurses Day on Capitol Hill, where we take our political agenda to those in Congress. And you're also welcome to meet us in the city of Atlanta in August for our annual convention. At that convention, I completely expect to be instilled as NBNA's next national president. Again, I really want to thank you for your time. And anybody got a question? Or was I just that amazing? No, but seriously, thoughts, questions, feedback.
Sheldon,
Yes.
I don't have a question for you.
Okay.
I just really want to thank you for sharing your knowledge on an incredibly important topic for all of us. And for folks who don't know me, I'm Craig Phillips. I'm currently president of the Canadian Association of Nurses in AIDS Care and at the University of Ottawa. And I've known Sheldon and many of you in the room for way longer than any of us care to admit.
A couple of decades.
And it's so great to see us actually having these conversations. These are conversations that I know you and I have had.
Absolutely.
Walking around different places and stuff.
Yes.
So thank you, thank you.
You're more than welcome. Anyone else, while you look at this absolutely fabulous picture of me? Isn't it lovely? I thought it was very nice. Go ahead.
Sheldon, it is really true. It's a great picture of you.
Thank you.
Joachim Voss from Case Western Reserve University. Where do you send your colleagues when they are interested in becoming diversity officers?
So that's interesting because there's... Go ahead, Michelle. Go ahead.
That's actually what I was going to say. Michelle Crespo Fierro, New York chapter. So the AACN has a Diversity Leadership Institute.
Yep.
Applications are open until November 30th, so
Yep.
you got to be quick. I just did, I was part of the second cohort. This is an amazing opportunity to learn about being a diversity officer with like-minded individuals.
Yes.
It is a profound experience. You receive mentoring, you perform a capstone and propose that, but it is just absolutely amazing.
So that program, that program is good, and it's one of the only ones that's really out there that's specific for nursing. That's specific to nursing.
Yes.
There's a few programs out there. You know, there's the DEI certificate through the Cornell Extension where you can do some stuff as well. But honestly, I get a phone call or an email almost every week from somebody who wants to know how to do this, and so I'm finding out that I'm mentoring quite a few people, which I don't mind doing, but you got to be genuine because this is hard work, and you got to be willing to take some hits because you're not always going to be the most popular person in the room. You're just not. So, other questions? Oh, from my understanding, the Robert Wood Johnson Foundation is also, when they're revamping their whole portfolio, they're going to come out with something as well. Dr. Wharton.
Dr. Fields.
Yeah.
Nice to see you again. Excellent. So I just wanted to follow up on Dr. Voss's question in terms of other resources. So there is another organization called NADAHI, the National Association of Directors of diversity officers in higher education.
Higher education.
They have an annual conference. I think the next one is in January or February, somewhere around there. But it is an excellent conference, and so it's not nursing specific, but it does have a broader swath of higher education, and it does have a specific health professions special interest group.
Right.
So that's one thing. I want to follow up on some of the comments that you made. So Mitchell Wharton, University of Rochester, and in full disclosure, I'm also an associate dean for equity and inclusion at my institution. And so the points that you pointed out in terms of schools wanting to have associate deans or assistant deans, that's great. It is a start.
Yep.
The work that needs to happen is not dependent upon just the people in those positions.
No.
It's dependent upon every single member of the faculty, the staff, the students, and the community in which you are engaged in. So I just want to put that out there to make sure that we reify that the work that needs to be done is not the work of one individual. It is the work of all of us, all the time.
Yep. So thank you for that, Dr. Wharton, because I actually told my dean, she made a comment in a meeting. She was like, oh my God, our numbers of diverse students are up, and we have Sheldon. I was like, oh no, back up, because I'm one person. If this work is not everybody's work, it's not nobody's work. Yes.
Hi, Natalie Wilson, UCSF. I was wondering if how you felt about making a request of our universities to admit a certain number of students. I guess maybe like some sort of affirmative action.
So I'm
thinking about the
I hear your
pipeline.
point, but I'm going to stop you right there.
Okay.
Because the Supreme Court is getting ready to come down with a whole decision about affirmative action that's going to screw us.
I know.
So we can't do quotas. It's just illegal.
Well,
What we need to do is holistic admissions, and what we need to do is, as a nursing profession, we need to fight for the federal resources as a profession to give us the money to do what they know we need to do to increase the ability to admit everybody to nursing school. We need to stop thinking about nursing school admissions as a pie, because here's the problem with a pie mentality. If you have one pie and I give you a biggest piece of pie, this other person over here now is get all mad because they got a smaller piece of pie. We need to stop thinking about this. We are more creative. Guess what? Let's bake a whole lot of different pies. Let's bake bigger pies. Let's bake more pies. Now, damn it, I want some pie. But I'm sorry, finish your question. I know.
Yeah. So it definitely wasn't, I wasn't thinking so much as affirmative action type thing, but like having qualified students, like you pointed out that there are qualified students
80,000
that
every year
are not getting into the programs.
Yep.
And in our communities, when I'm out there, they're like, we need more Black providers out here. I mean, so the demand is out there, and yet we're creating this pipeline that becomes more constrained to bring in people. So I guess my question is how do you suggest, or what kind of thoughts do you have in addressing that so that we open up the pie, as you were saying, but there's got to be some type of request that's made.
Okay.
Paid preceptors.
Say that again?
Paid preceptors.
Oh, yeah, we definitely should do that. I think we absolutely should do that. But that's at the advanced practice level as well. Again, now we're back to that resource question. And guess where most of the resources are? Guess where most of the resources are to train every single physician in this country? They come through the Center for Medicaid and Medicare Services. It is your tax dollars. We need to reallocate. It's about resource allocation. So my understanding, that was the last question, because you all need time to get into whatever outfits for this gala, Dr. Chandler. Thank you all again. I'll stay. I'll answer questions.
Questions? Get the mic.